sudden discontinuation of SSRIs or SNRIs or any agents that have a prominent serotonergic activity. We know that serotonergic agents suppress REM sleep, and therefore stopping SSRIs or SNRIs or other serotonergic potentiating agents can result in a prolonged rebound REM sleep replacement. So therefore, individuals are spending a lot more time in REM sleep, and this can be associated with increased tension, dread, and a reduction of sleep quality because individuals aren't really going into the non-REM sleep. The other issue is this REM rebound can increase the risk of relapse. It can worsen withdrawal symptoms and can actually lead to depression or anxiety, morphing into a more severe agitated melancholic depression. In clinical practice, early morning awakening is a clue towards the more severe agitated depression from a sleep perspective. In fact, in melancholic depression, early morning waking is a core feature. Patients describe significant psychomotor agitation immediately upon awakening. They often describe the moment I wake up, the thoughts come back with a bang. I feel extremely anxious, or describe it as the dread comes back straight away once I wake up first thing in the morning. This is very much in contrast to the normal waking process. From a neurobiological perspective, the reduced serotonin, which is a feature of REM sleep, and we know as we come closer to waking up, we are going through more REM cycles. So reduced serotonin in these REM cycles, along with impaired 5-HT2A and 5-HT2C activity, can result in reduced GABAergic tone and increased noradrenaline activity. So this combination lowers the intrinsic threshold of the amygdala in response to stressful events. So it results in a hyper-responsive or hypersensitive amygdala, and therefore stresses in the environment can result in an exaggerated effect. And this is seen in clinical practice where patients may come off medication sooner or may stop medication suddenly, SSRIs or SNRIs. One's got to recognize that in some of these individuals, there might have been a REM sleep rebound, and therefore it's extremely important to evaluate sleep when coming off medication in general, because in the context of stresses and amygdala hypersensitivity, this combination can act as a significant risk of relapse towards major depressive disorder, and as I mentioned, morph the depression into a more severe agitated depression. This is described quite well in the article by Kovalzon. The long pre-morning periods of REM sleep become especially dangerous since they can reduce the level of cerebral serotonin below a certain critical level, the threshold for disruption of general serotonergic transmission and the occurrence of emotional disorders. This approach is confirmed by the subjective reports of patients reporting the appearance of the first feelings of depression even during the experience of morning dreams, and reaching their maximum severity immediately upon awakening. However, by the evening, as serotonin accumulates in the course of a vigorous state, the patient's condition gradually improves. Depressive symptoms go away by themselves and they feel completely healthy until a new period of sleep comes. This is classically the diurnal variation that's been described, and we know this occurs in melancholic depression. It is clear that against the background of a low near threshold level of cerebral serotonin, even immersions in non-REM sleep causing a decrease in serotonin release can relaunch pathological processes in the brain.